Right, so these are my notes on Hemat. Um, this should be a quick one, I hope. Um, and I hope you're a fan of Inception because this is a video that I took from my wall, and now you're watching the video. So it's a video inside a video. All right. So first note: polycythemia vera, facial plethora. You get ascites, abdo, right upper quadrant pain, with distension in abdo, and tenderness hepatomegaly and tender splenomegaly. This is called. This is because of Burd-Chiari syndrome. Diagnosis: you do abdomen Doppler uh, ultrasound. Okay. Um, all right, I'll go cross as well. Uh, Autoimmune hemolytic anemia and hereditary spherocytosis. So there's a comparison between the two. They both have spherocytes. However, direct Coombs test is going to be positive only in autoimmune hemolytic anemia. It's going to be negative in hereditary spherocytosis. There's a different note that hypercalcemia leads to constipation. All right, just remember that. Hypercalcemia leads to constipation. Multiple myeloma, crab. So you see crab in there. That's hypercalcemia, renal dysfunction, anemia, and bone pain. Right. EPO, uh, severe hypertension. It causes severe hypertension. Is common adverse effect. Drug-induced immune-mediated hemolytic anemia um, due to penicillin and cephalosporin. Okay, that will cause drug-induced immune-mediated hemolytic anemia. Graft versus host disease in. I'm trying to get a better. Okay, we'll work with this. Oh, no, I think I was too fast with that one. Anyways, graft versus host disease in bone marrow transplant from twin uh, HLA match, right? Um, this is due to activation of the donor T lymphocytes. Okay, so the twin that's donating, their T lymphocyte is gonna attack the things in the host. Um, that's why you get graft versus host disease in bone marrow transplant from twin. Okay. You get skin. So skin is affected, intestine and liver affected. Um, in it, INH. Oh, isoniazid. Isoniazid causes pyridoxine B6 uh, deficiency, right? Because it is a pyridoxine B6 inhibitor, isoniazid. This will lead to hyperchromic microcytic anemia. Okay. Breast cancer metastasis to bone. Treatment here is bisphosphonate therapy. In mild hypercalcemia, this presents. So this prevents hypercalcemia and prevents osteoclastic activity due to malignancy. Okay. Death in Hodgkin's lymphoma. So in Hodgkin's lymphoma, the thing is, if they get treated and cured, the chances are that during their lifetime they have increased risk of another malignancy. I think they said solid malignancy, so like lung cancer or something like that. So this is the prevalence. This is the years of after treatment. Okay, so if recurrence risk, it rises significantly up till here, and then it stays there for throughout their life. Okay, years after the treatment. Chances of second malignancy increases after 5 years of being lymphoma free. Right, so increased risk after 8 to 10 years. Sorry. Okay. So recurrence risk of lymphoma is increased in the first 8 to 10 years, and then second malignancy increase in risk after 8 to 10 years. Hopefully that makes sense. Okay, so this is the reason for mortality in Hodgkin's lymphoma or due to thereafter. Waldenstrom, macroglobulinemia, and giant cell arteritis. Gamma gap, total protein albumin. Okay, so gamma gap, this is total protein minus albumin, so whatever is left over. Okay, there will be it's going to be positive for Waldenstrom, negative in giant cell arteritis. Jaw claudication, it's going to be positive in both of them. Okay, visual changes is positive in both of them. ESR is positive in both of them. Peripheral neuropathy, it's negative in giant cell arteritis, but positive in Waldenstrom macroglobulinemia. Same thing with renal insufficiency, it's negative in giant cell arteritis, but positive in uh, Waldenstrom macroglobulinemia. Temporal area tenderness, it's going to be positive for giant cell arteritis, but negative in Waldenstrom macroglobulinemia. Okay, whoops. So gastrointestinal blood loss is most common cause of iron deficiency anemia, especially in patients more than 50 years of age. Do endoscopy. Iron is absorbed in duodenum, if you didn't remember that from step one. Osteoblastic bone focal lesion. Uh, this is a sclerotic lesion. Um, it is it leads to prostate adenocarcinoma. Okay, or it's caused by prostate adenocarcinoma. They're related, right? But remember that osteoblastic bone lesions are sclerotic, right? Because it's bone is building one, so it builds on top of it. Okay, kind of missed that one right there. Oh, let's see. Okay, that's better. Hemolytic anemia, jaundice, splenomegaly, uh, leads to hereditary spherocytosis, acute cholecystitis, uh, pigment. Uh, Let me make this smaller so it might be better for you to see it. Okay. Right. So hemolytic anemia. If you have a patient with hemolytic anemia, jaundice, and splenomegaly, chances are they have hereditary spherocytosis. Okay. Um, this can lead to acute cholecystitis, and you will see pigmented gallstones, and you will see fever, right upper quadrant pain, positive Murphy sign, and leukocytosis. Okay. Waldenstrom macroglobulinemia, hyperviscosity syndrome, diplopia, tinnitus, dilated fundoscopy findings, and headache. Okay, so hyperviscosity syndrome. We just did Waldenstrom right here, so you have it over there as well. You will have neuropathy, right? You'll have bleeding, as in anemia, hepatosplenomegaly, initiative, infiltrative disease, anemia, thrombocytopenia, and lymphadenopathy as well. Increase in immunoglobulin M, bone marrow biopsy, 16, more than 10% clonal cells, and rouleau formation is also seen here, similar to multiple myeloma. Okay. Superior vena cava syndrome, most common cause is lung cancer or Hodgkin's lymphoma. Okay. Superior vena cava syndrome is where there's anything that's causing kinking or blockage or obstruction of the superior vena cava. Okay. So what do? You do chest X-ray and histo to determine the type of tumor. Cancer metastasis is common to adrenal glands, uh, which you will give you findings of decreased serum sodium, increase in potassium. Okay. Uh, Diagnosis is cholecystropin stimulation test. This is a ACTH stimulation test. That's what this is. Cholecystropin stimulation test. Okay. Cancer metastasis is common to uh, adrenal glands, and it's seen from hyponatremia and hyperkalemia, and diagnosis is made by doing cosintropin stimulation test or ACTH stimulation test. Okay. PET scan or positron emission tomography scan with 18 fluorohydroxyglucose something, right? FDG. Um, this will show positive in nodes and in healthy organs. Um, so chances are you have Hodgkin's lymphoma. Okay. So yes. So if you get a positive positron emission tomography scan with 18 FDG, you might think if you have it like in let's see lungs or something. Um, Actually they pick up this scan. So even if you don't have lymphoma, it may pop up in the scan. However, if you have it in nodes, chances are you do have Hodgkin's lymphoma then. Okay. Thalassemia is hemoglobin defect. So why does it show up in healthy organs? It's because I guess they absorb this stuff. I forget the explanation for this, but I think there was a question where they're like, it's seen in the lungs or the muscles or something, and they're asking why is this happening? What or what is the significance of this? So it was just that their demand is more over there in those areas. Okay. Uh, Another note is thalassemia is hemoglobin defect. Okay, it's a defect of hemoglobin, not any chains or something else. I think I remember what it was, but this should be obvious. Okay, vitamin B12 deficiency. Uh, this will cause long-term effect of and okay, so vitamin B12 deficiency, long-term effect, and gastric cancer. So this will cause shiny tongue and pernicious anemia. Okay, and pernicious anemia, antibodies will cause intrinsic factor. Okay, uh, in, sorry, antibodies will attach to intrinsic factors, and it will cause, you know, gastric parietal atrophy or whatever, and then damage, gastric atrophy, right? And that will lead to gastric cancer. So that's where you get vitamin B12 to gastric cancer. All right. Okay, so thrombocytosis, less than 50,000. That should be thrombocytopenia, I guess. So thrombocytopenia less than 50,000 with bleeding gums and heavy menstrual bleeding. Think SLE. The thrombocytopenia is due to peripheral destruction in SLE. Okay. Flying at high altitude or alcohol consumption will cause dehydration in patients with sickle cell trait or disease. Okay. Intravascular hemolysis. This will cause intravascular hemolysis or tissue damage, ischemia, for example. Splenic infraction and vaso-occlusive pain. It will cause all of these things in sickle cell traits if they're flying at a high altitude or alcohol consumption. Diagnosis here is electrophoresis. It happens in people from patients from India, Africa, Central South Americas, Middle East, or Mediterranean patients. Okay. Target cell. Um, think thalassemia. Uh, and the history will have the patient from Italian, be it Italian or from Greece. Um, Another note is hepatic vein thrombosis, proximal nocturnal hemoglobinuria. Okay. Treatment here is prednisone, E. coli. What is this? Oh, equilizumab. Okay. That's what that is. Equilizumab. Give wax against and meningitis if they have this. Okay. If they have proximal nocturnal hemoglobinuria, treatment is prednisone. and equalizumab give vax against meningitis in this. So hepatic vein thrombosis may, may be caused by proximal nocturnal hemoglobinuria. Okay, PNH. Uh, Heavy menses plus diffuse myelinosis, myalgias. Sorry, heavy menses with diffuse myalgias plus platelets are less than 100. Okay, think immune uh, ITP, immune thrombocytopenic purpura. Diagnosis here is uh, you check for Hep C, HIV, SLE, and in this case, you would check ANA for SLE, right? Which they're on page 285 of first aid. Okay, okay. I think that's the best it's gonna do. Cancer pain management, chronic cancer-related pain. Okay, so how do you manage it? If it's mild, you give non-opioids, acetaminophen or NSAIDs, with or without adjuvants, that is glucocorticoids, antidepressants, or anticonvulsants. And if that is not adequate enough, then you give this for inadequate relief, which is short-acting opioid, oxycodone, morphine, with or without non-opioid with or without adjuvants. Okay, but if it's moderate, you go straight to this path. So moderate or severe, that is a pain level is anywhere from 4 to 5 out of 10. Okay, this was between 1 to 3 out of 10. Okay, so for that, oxycodone, morphine, again, non-opioid or adjuvants, multiple daily doses or sleep interruptions. Then you go to long-acting opioids. These are your ER morphine. ER is extended release morphine, fentanyl patch with or without non-opioid and adjuvants, plus short-acting opioid for breakthrough pain. Polycythemia vera, we already covered that. But anyways, manifestation: increase in blood viscosity, hypertension, erythromyalgias, burning cyanosis in hands and feet, transient visual disturbances, increase in RBC turnover, gouty arthritis, aquagenic pruritus, and bleeding. This is the one where hot water causes itching. Why? It's because um, polycythemia vera, it causes increase not only in RBC line but all the other uh, cell line lineages, right? Including mast cells. So now that normally you have low amount of mast cells and heat uh, produced during taking hot showers would cause uh, degranulation. However, it's not a significant amount, so you don't feel the itching or whatever. But now that due to polycythemia vera, there is significant amount, enough amount to cause itching uh, due to the release of mast cells and its granules. Okay. So examination of facial plethora, you can get that in PCV and splenomegaly. Lab findings are elevated hemoglobin, leukocytosis, and thrombocytosis, low erythropoietin level, JAK2 mutation positive. Complications here are thrombosis, myelofibrosis, and acute leukemia. Treatment here is phlebotomy and or phlebotomy, um, hydroxyurea if increased risk of thrombus. Okay, alpha thalassemia and beta thalassemia, there's just a difference between the two. So in alpha thalassemia, it's one gene deletion, normal, two gene deleted, mild anemia and normal electrophoresis, three gene deleted, then you get moderate anemia with hemoglobin H, which are beta 4 tetrads, increased reticulocytosis. And if you have four genes deleted, then gamma 4 tetrads, or you have hemoglobin part, congestive heart failure causes the death in utero. So in alpha, if it's just one gene deleted, you still have normal life. Two gene deleted, it's mild anemia, but still normal. It's where you have three deleted ones, that's when you are in trouble. And in beta thalassemia, since you only have two, If one gene is deleted, minor is HbA slightly decreased and HbA2 and HbF up slightly, but normal life expectancy nonetheless. If both of them are deleted, two genes defective, uh, then you have major thalassemia or beta thalassemia. Little or no HbA increase, HbA2 and HbF. Often die by age 30. Okay, they covered this pretty well in the uh, first aid for step two, and there's already a video on that I made. So, phenytoin, what does it do? It inhibits folic acid. Okay, so if you're having the telltale signs of folic acid deficiency and they're on phenytoin, then phenytoin is most likely the culprit. But the telltale signs are not going to be obvious in the vignette, so look out for it. If you're starting to seeing anemia and all these random stuff that's happening, maybe even CNS symptoms, and it's pointing to like something else. If they're taking phenytoin, uh, try really hard to cross that out because usually that's the culprit. Okay. Tumor lysis syndrome. Okay. Tumor lysis syndrome. So treatment here is prevention is allopurinol. It reduces new urate formation, but if it's currently hyperuricemia, then raspberry case. Okay, it breaks down urate. Okay. Hematologic manifestations of SLE. Uh, Common mechanisms are anemia, leukopenia, and thrombocytopenia. So anemia is through anemia of chronic disease, SLE nephritis, iron deficiency anemia, gastrointestinal loss, and immune hemolytic anemia. Uncommon mechanisms for anemia are medications, MAHA, and aplastic anemia. MAHA is microangiopathic autoimmune hemolytic anemia, okay, and aplastic anemia. And then you have leukopenia, immune-mediated destruction, okay. Uncommon mechanism is again medication, and bone marrow dysfunction. Thrombocytopenia, immune-mediated destruction again, and again here you have uncommon mechanism is medications, and TTP, which is thrombotic thrombocytopenic purpura, and increase in consumption because of that. Okay. Iron studies in microcytic uh, anemia, TAIL, TAIL, thalassemia. A was for anemia of chronic disease. I was for iron deficiency anemia. L was for lead poisoning, right? So it's just telling you what the error findings are. In iron deficiency anemia, MCV, all of these are going to be decreased except for anemia of chronic disease because it depends on if it's early or late. I believe the late one is where it's going to be decreased, and if it's early, then it's going to be normal. Iron deficiency, obviously, iron will be low. Ferritin, the storage form of iron, is also going to be low. And transferrin, the transport saturation one. Sorry, that's this one. So the seats where iron, basically the things that pick up iron and move it around, you're going to find a lot of those, the taxis, right? The taxis are going to be empty, and there are going to be plenty of those. And transferrin saturation, the taxis are going to be empty, right? So um, there's going to be very low amount where there are passengers in those taxis, right? So transferrin saturation is going to be low. That's what it means. It's where iron is bound to TIBC. You will find very few of those. Thalassemia, MCV again, it's going to be very low. It's going to be decreased. Iron is going to be either normal or increased because this doesn't have any effect on those. Even ferritin, same thing, and transferrin saturation. It has nothing to do with iron. Anemia of chronic disease, this thing does have something to do with iron. It's inflammation, MCV, we covered that. Iron, it's going to be low, but however, the storage form is going to be increased or normal. It's because your body is physiologically prepared, and there's a protocol in your body where if you have inflammation or infection or something, they save all the irons because the bacteria or whatever organism you're infected with, they try to seek iron, and that's how they proliferate apparently. So ferritin is where it hides it, uh, either in the lymph nodes or WBCs or whatever, right? Macrophages. Transferrin is the transport one. The taxis are now, called back. You don't want taxis traveling around because if they're there and they find iron, they're going to pick it up. So they don't want that. So transferrin is going to be low. And again, taxis with those irons, it's going to be low or normal amount. Okay, because if it's already bound, then it can't be used by other uh, organisms, I guess, which is looking for free iron. Okay, next. Drug-induced immune-mediated hemolytic anemia. Pathogenesis: drug coats erythrocytes, and then you have immunoglobulin G binding, and then those, when they reach the spleen, there will be splenic destruction of RBCs, extravascular hemolysis. Drug triggers immune complexes, right? So complement mediated destruction of RBCs, intravascular hemolysis. Manifestation is sudden onset within hours of exposure, anemia, fatigue, pallor, dyspnea, hemolysis, jaundice, dark urine, abdominal or back pain, reticulocyte, um, indirect bilirubin, and LDH, decrease in heptoglobin, spherocytosis or peripheral blood smear, uh, plus direct Coombs test, anti-IgG and anti-C3. Treatment here is discontinues offending drug, transfusion if severe, and with or without glucocorticoids. Uh, IVIG is intravenous immunoglobulin. Right. Okay. So that was the treatment. Transfusion, discontinue the drug, and glucocorticoids, IVIG. Okay. So you'll get jaundice, dark urine, abdominal or back pain, increase in reticulocyte, indirect bilirubin and LDH, decrease in heptoglobin. Heptoglobin, why? Because they bind uh, hemoglobin. So the hemoglobin that gets leaked out from the ripped RBCs, um, all those get picked up by haptoglobin. So now you won't have free haptoglobin running around because they're being all used up by the ripped RBCs, hemoglobin. Spherocytosis on peripheral blood smears. Okay. And that's usually a sign of splenic infraction or whatever, right? Or any type of damage to RBCs. And direct Coombs test, that is just a test that tells you that there are antibodies against the RBCs. That's what that test is for. Anti-IgG and anti-C3. Okay, sudden onset within hours of exposure and fatigue, pallor, dyspnea, anemia. Okay. Another note, clues for increasing index of suspicion for Legionella pneumonia. Okay, clues for increasing index of suspicion for Legionella pneumonia: exposure to possibly contaminated water. This is recent travel, especially cruise or hotel stay within the previous 2 weeks. Contaminated potable water in hospitals and nursing homes. Okay. Clinical clues are fever is more than 39 degrees Celsius or 102.2 Fahrenheit. Bradycardia relative to high fever, neurologic symptoms, especially confusion, gastrointestinal symptoms, especially diarrhea, and unresponsive to beta-lactam and aminoglycoside antibiotics. Lab clues are hyponatremia, that's the most important one. If you have hyponatremia and some of these clues, you can blindly just pick Legionella. Hepatic dysfunction, hematuria or proteinuria, sputum gram stain showing many neutrophils but few or no or microorganisms. All the other ones are pretty vague. They overlap with many other stuff, but hyponatremia with fever and all of these things is very rare. It's very, not that it's rare, it's just very classically about points to Legionella pneumonia. Okay. Key. No, no, don't too fast, bro. Okay. Drug-induced neutropenia. Common triggers here are methimazole, propylthiouracil, TMP-SMX, clozapine, and sulfasalazine. Mechanism here is immune-mediated drug or metabolite binds to neutrophils and trigger a cell-mediated or humoral response. Bone marrow toxicity, drug or metabolite directly or indirectly damages granulocyte precursors. Okay, it's similar to that drug-induced one that we just read before, right? Now, manifestations here usually within 3 months of drug exposure, oropharyngeal ulceration with or without fever, other cell lines unaffected. Management here is discontinue inciting medications, antibiotic inciting of treatable infection, and consider granulocyte colony stimulating factor. Okay, again, the common triggers, and those are the important ones for drug-induced neutropenia. It's methimazole, PTU, TMP-SMX, clozapine, and sulfasalazine. Clinical manifestations of hereditary hemochromatosis. Skin here is hyperpigmentation, right? Bronze diabetes. It's a pretty classic one from step one. Musculoskeletal arthralgia. You'll have arthropathy and uh, chondrocalcinosis. Uh, Gastrointestinal elevated hepatic enzyme with hepatic uh, hepatomegaly early, cirrhosis later, and increased risk of hepatocellular carcinoma. That's the important thing right there. That someone with hereditary hemochromatosis, their fate is hepatocellular carcinoma. Um, Endocrine, DM, secondary hypogonadism and hypothyroidism, um, cardiac restrictive or dilated cardiomyopathy, and conduction abnormalities. Infection, increased susceptibility to listeria, Vibrio vulnificus, and Yersinia enterocolitis. Um, and another similar one with this that we confuse it with is Wilson's. That's the one with the copper, and you see the eye ring, and it shows up on basal ganglia scan on brain scan around basal ganglia, right? Another thing that causes basal ganglia uh, contrast or whatever, where you see it shine on MRI scan was carbon monoxide poisoning. Okay. No, no, too fast, too fast. That's the last one. Okay, that's good. Transfusion. Let me put it down a little. Transfusion reaction associated with hypertension. Okay, you need to know this anyways, and I would recommend going back to the step one book. They explain it really well. However, some things differ in this than that, so we'll just cover that here. Anaphylaxis onset is seconds to minutes, right? It's right away while they're doing, they're operating. If it's happening right there, then it's happening. They're having an anaphylactic reaction. Cause here is recipient anti-IgA antibodies. Okay, so that's why you got to give them uh, blood that is lacking of IgA IgA or IgA antibodies. Okay. Clinical feature here is shock, angioedema, urticaria, and respiratory distress. transfusion-related acute lung injury, minutes to hours, donor anti-leukocyte antibodies, respiratory distress, and non-cardiogenic pulmonary edema, uh, bilateral pulmonary infiltrates. Okay, so minutes to hours. This is transfusion-related lung injury. This is the one where you will have respiratory distress. Okay, it's because of donor anti-leukocyte antibodies. Okay, so it's donors WBC uh, antibodies against those. Okay, so donors anti-leukocyte antibody. Okay, so the WBCs that are coming from the donor blood are attacking the host cells. Okay, um, attacking the host. Okay, so that's the transfusion related acute lung injury, and the host will present with respiratory distress and non cardiogenic pulmonary edema, bilateral pulmonary infiltrates. Acute hemolysis, minutes to hours, HBO, sorry, not HBO, ABO incompatibility. Okay, so I'm zoning out here, sorry. But acute hemolysis, minutes to hours, again, that's similar to this. However, here you will present with fever, flank pain, hemoglobinuria, and DIC. Okay, so black urine or red urine, and flank pain is the giveaway here, acute hemolysis, right? And DIC. So this is because of ABO incompatibility. And then you have bacterial sepsis, minutes to hours, same thing. Um, this will present with fever, chills, septic shock. So hypotension is crucial to point out here, and DIC. This is because of bacterial contamination of donor products. And that's it. Thank you, and I'll see you in the next one.